For my case study presentation, I decided to choose an eye-to-thigh F18 tumor imaging study. This is a study I more or less did myself, with the exception of placing and administering the radiopharmaceutical, and I'll get more into the details as to why that was later on. But to start off, I wanted to review exactly what a PET-CT scan is. Positron emission tomography, PET, uses radiopharmaceuticals to evaluate organ and tissue functions by identifying changes at a cellular level. Computed tomography, CT, uses X-rays taken from different angles to provide anatomical information. Put the two different scans together and you get the best of both worlds. Patient history. The patient for this specific study was performed on a 60-year-old Hispanic female with a 10-year history of metastatic colon cancer that was first diagnosed in 2010. She was referred to Simon Med Imaging for a CT scan with contrast to reevaluate the extent of the colon cancer. Here is the CT report. As I mentioned, the indication for the initial CT was the patient's history of colon cancer, so the areas of interest were the chest, abdomen, and pelvis. Continuous axial images of the areas of interest were obtained after contrast was given intravenously. The contrast that was used was Omnipaque, and 100 milliliters were used. The patient's blood was drawn prior to contrast administration for an iStat analysis. And for those who don't know, an iStat analyzer is essentially a portable blood chemistry device. There are different kinds which test for different things. On the right of your screen, you will see an example of an iStat analyzer, which is looks really similar to the ones that we use at Simon Med. Which brings me to my first question for you guys. Why do you believe an iStat analysis was performed prior to the administration of Omnipaque, which, remember, that was the contrast used for the CT administration? I'll let you think about that for a couple seconds. And a little hint, the two values that they tested for with this specific iStat analyzer and for this specific patient was creatinine and GFR, glomerular filtration rate. Here's the answer to the first question. According to the FDA, Omnipaque is eliminated from the body unchanged by glomerular filtration, so through the urine. They wanted to make sure that the kidneys were up to the task of eliminating the contrasting agent from the body. From the CT report, an iStat analyzer test of the patient's blood was done due to the patient's older age, and she's 60 years old, and she had no recent lab work. Creatinine was 0.6 milligrams per deciliter, normal range being 0.5 to 1, which she's in the normal range. And that's the 0.5 to 1 is milligram per deciliter is the range for women. And the GFR was 99 milliliters per minute, normal being anywhere greater than 90. So her creatinine and GFR were normal. So obviously with those values, they were within the normal limits, so the contrast was administered for the CT. Here is our first CT image. We have a little excerpt from the CT report. The radiologist states that there is a newly seen consolidation at the anterior left upper pole of the lung. There are also numerous newly seen small nodular opacities scattered through the left upper pole of the left lung, and to a lesser extent within the lower lobes. There was a previous CT from 2017 that the radiologist did his comparisons to. And for the record, I am 85% sure I placed the arrows in the right place on this image. So right here, that's the new nodule that they've seen that was not on the previous CT scan. I hope you can see my cursor, but the arrows are pointing to right here, if you can't see my cursor. And with the CT report, no pleural effusion and no thoracic aortic aneurysm. Here is another CT image. So if we remember towards the beginning of this presentation, the initial CT was ordered due to the evaluation of colon cancer and the check for Mets. Now that we see new lesions in the lungs, that is a bit concerning. The radiologist suggested a PET CT scan, which brings us to the study that was performed. I'll let you take a look at that excerpt from the CT report. Here is another CT image. Those arrows are pointing to irregularities. And here is more excerpt from the CT report. I'll let you guys read that. Feel free to pause if you want to read into that a little bit more, but we're going to move on. And this is the impression that the radiologist had. Newly seen left upper lobe consolidation. There are also numerous newly seen small nodular opacities scattered through the left upper lobe within the lower lobes and to a lesser extent. And at the bottom you see that a PET CT should be considered to further evaluate these findings. So when I looked at their initial report for the PET CT, it was for a solitary pulmonary nodule. So I did do my peer review article on solitary pulmonary nodule. So I'm going to take this slide to just chat about it and talk about certain definitions and whatnot. So according to Mosman and Borba and Negromonte de Macendo, probably said that one wrong. A solitary pulmonary nodule is classified as being a single, round, and well-circumcised opacity nodule with a circumference of greater than or less than 3 centimeters. It is characterized by being completely surrounded by pulmonary parenchyma. According to the peer review article found on the U.S. National Library of Medicine, National Institute of Health's website, a solitary pulmonary nodule are a relatively common radiographic finding, as well as a CT finding, which is usually an incidental finding when reviewing chest x-rays and CT scans. I realize this study was a couple of decades ago, but I do feel it is an interesting little tidbit. A 1959 study in Brazil has showed that 1 out of every 500 chest x-rays will show a solitary lung nodule. Whether or not that nodule is cause for concern depends on further testing. 20% of suspicious nodules found in radiographs end up being associated with alterations mimicking solitary pulmonary nodules, like rib fractures, sclerotic bone lesions, skin lesions, electrodes, or nipples have all been reported as suspicious lesions in the past. PET is a nuclear medicine imaging method that allows for a non-invasive evaluation of a range of biological processes, with the most widely used radiopharmaceutical being F-18 FDG. which is a glucose analog. This radiopharmaceutical is great for evaluating the likelihood of pulmonary nodules being benign or malignant, because it enters the cells through membrane receptors, and once in the cell's cytoplasm, it gets converted to F18-FDG6-phosphate, becoming trapped in a metabolically active cells, since it does not follow the subsequent intracellular glucose metabolism route. So, if that lung nodule on a PET-CT scan shows increased activity, it can be equated to a higher possibility of it being malignant versus benign. PET-CT the day of exam. The day of exam, which was around September, early September, the patient was scheduled to be imaged at 8 a.m. At my site, we request that all PET patients arrive 90 minutes before their imaging time. The patient was called the day before and was told to arrive fasted. Besides being fasted for a minimum of 6 hours, no other patient preparation was needed for this study. I greeted the patient in the waiting area, where I quickly discovered that my first complication, quotations, of the study were present. The patient only spoke Spanish, though she did seem to understand English, thankfully. She verified her identity by giving me her last name and her birth date, and then I escorted her to one of the injection rooms and proceeded to ask the following questions. This is a photocopy of the PET-CT questionnaire that we had for all of the patients. The patient filled out the majority of this online, so I did go down the list and confirm what she already inputted, as well as confirm that she fasted, which she was. So I hope you can see my cursor. If not, we're doing the PET-CT scan today because of a suspicious nodule in the chest, as well as her history of colon cancer, so new lung nodules as well. This is not her initial radiology procedure for this condition because she's had CT scans in the past. She had a CT. Her most recent CT was the 14th of August. Like we talked about earlier, she does have a history of cancer, which is colon cancer, that was diagnosed in 2010. She had chemotherapy around 2 years ago, which it is important to ask when their last chemotherapy was done, because I've learned that if, for instance, if she had chemotherapy yesterday, there will be lots of activity in her bone marrow, which may change how you process the image. No history of radiation therapy, and she's never smoked, or rather, she quit a long, long time ago. I do remember asking her how long she quit, and I was unable to get an answer from that. She has no recent injuries or trauma to the body. She has not had any surgeries within the past year. She is diabetic, and she does have high blood pressure. Which brings us to our second question. What was the radiopharmaceutical that was used for this PET-CT study? F18-FDG. Follow-up question. What does FDG stand for? Fluorodeoxyglucose. Good job. What is the typical dose for an F18-FDG PET-CT tumor scan? I do realize that the typical dose is institutional dependent. Around 10 millicuries. At my site, we can go 10% above and below that prescribed dose. My CI told me that on the Simon Meds, the PET-CT F18 dose for an eye-to-thigh tumor imaging study does vary, specifically depending on how old the camera is. So there's a site, I don't remember where, I want to say maybe Greenfield, where their F18 dose is higher than 10 because it's an older camera. And I believe Estrella, Simon Van Estrella, has like one of the newest PET CT machines. So they can go as low as like 8 or 7. What is the physical half-life of F18? 110 minutes. Good job. And what is the energy level of F18? 511 keV. Nice. You know your radionuclides. After confirming that what was on the PET CT questionnaire, I then proceeded to explain the procedure. I explained that her doctor ordered a PET CT scan to evaluate the nodules that were found in her lungs during her previous CT scan. I explained that I will be placing a small IV into her arm and injecting a radiotracer that is essentially radioactive sugar that will allow us to metabolically image the area between her eyes and thighs. I explained the reason why we asked that she was fasted, because we wanted her tissues to be hungry for the sugar. The hungrier her tissues, the more the tracer will uptake in the areas that we want it to. I told the patient that after administering the medication, she will stay in the injection room for about 60 minutes while the tracer goes where it needs to go. But before I administered the F18, I had to check the patient's blood sugar. Question 3. Why must the patient's blood glucose be checked before an F18 FDG administration? High blood glucose equals poor radiopharmaceutical uptake. Because if the patient's blood glucose was too high, the tracer will not uptake very well within the patient's body, and you will get very poor quality images. The high-end cutoff for this patient's blood glucose at my site was around 210 milligrams per deciliter. The patient's blood glucose was 129, so it was okay to proceed with the scan. And so it was okay to proceed with the IV installation, which brings me to my second complication for this study. The patient was able to relay that she does not want her right arm poked under any circumstances. And remember, she was Spanish speaking only. So my options for placing an IV were already very limited from the get-go, since she pretty much implied that her right arm was a no-go. I placed the tourniquet on her left arm, and I was unable to palpate or visualize any vein in her left AC area. I did check her hand, and I did see one on her hand. So I grabbed the smallest IV catheter we had available, which was a 24 gauge, and I did poke. But as soon as I broke the skin and started to thread the catheter into the vein, which I was in, she jerked her hand away, and the catheter came out. And I was very upset internally. But I poked once on the hand. I just grabbed my CI to place the catheter and administer the radiopharmaceutical because we just needed to get on with the study, and I did feel comfortable trying again, but I just wanted to make all the pokes for this patient count. After the tracer was administered, we told her to relax in the injection room for 60 minutes. We told her just to stay as still as possible, take a nap if you want. We just didn't want her walking around the room, talking on her phone, anything like that, because that can increase the medication uptake in certain areas of the body where we really don't want it to uptake in. After an hour, I escorted my patient to the designated PET bathroom so she can empty her bladder. I made sure to verify that she didn't have any metal in the area of interest, so No large earrings, no bras with wires, no face mask with thick wires. I told the patient that the scan will take around 20 minutes and that she will go in and out of the PET CT tube 3 times. The first 2 times will be faster, which is the CT portion of the exam. The third time will be much slower, which is the PET portion. I told the patient to lay as still as possible, breathe normally, and then I had her lay on the imaging table with her arms raised above her head. I placed a cushion under her knees, as well as draped a blanket over her to keep her as comfortable as possible. Question 4. Why were the patient's arms positioned over their head for this particular study? If the arms were by their side, there will be more attenuation in the area of interest, which in this case were her lungs. I made sure to ask if she was able to hold her arms above her head for about 30 minutes, 20 to 30 minutes without moving. And she said she was able to, but if she couldn't, I would have just had her arms by her side. Better to have some attenuation than having to repeat the parts of the scan over because there was patient movement. After she was positioned on the table, I started to input her information into the acquisition computer, making sure her height and weight, pre-injection dose and time, injection dose and time, and post-injection dose and time were correctly inputted into the acquisition station. Question 5. Why is it important for PET CT studies in particular that the correct patient information, and I'm talking about like height, weight, dose, is correctly inputted in the acquisition computer? Before I get to the answer, this is more or less the information that I inputted into the acquisition station on the bottom. The answer is that so the correct SUVs are generated. If you enter in the wrong height and weight, doses, and times, the SUVs will be all out of whack and inaccurate. I made the mistake of, not on this study, but I made the mistake of forgetting the patient's weight once, and their SUVs were like in the 12s, which the liver SUVs rather was around 12, where usually it should be anywhere between 2 to 3. So we had to reprocess the image, and luckily on this specific GE PET CT camera, it's really easy to fix that issue. So I wasn't fired. After taking the image, I had her stay on the table as I scrolled through the axial slices to look for any patient motion. I paid close attention to the nasal bone and her upper arms as I looked for movement, because those are areas where if there's movement, it's easy to tell that the PET data and the CT data don't match up. She was a very good patient, so she managed to stay very still, so she was free to leave. Which brings me to processing. After the patient left, I sent my SCOUT, my CTAC, lung recon, and AC and NAC file over to IntelliViewer, which is the processing site that Simon Med uses. I fused the CT and PET images together, and I darkened the intensity of my MIP image and wrote down the SUV of the liver. The patient's SUV of the liver was 3.7, which is a little on the high side, but my CI said it was okay. And this liver value, the liver SUV value, is used for body background, and it's also used to compare the nodules the nodule SUVs that the radiologist measures for diagnostic purposes. My axial, sagittal, and coronal and MIP images were processed. I enter in my individual tech notes from the PET-CT patient questionnaire into the computer and set everything to the radiologist. And SimonMed reads their PET-CT images really fast. Usually takes about a day. A lot of the times they read them the day of. So the very next day, I checked the report, and the radiologist already reported it. So let's look at that as well as the PET-CT images. So this is the first image that's generated for a PET-CT scan. This is the SCOUT image. I used this image to make sure that the patient didn't have any metal on that will attenuate during the scan. I also use it to select the number of beds I wanted, so I moved the beds around to make sure everything was in the field of view that I wanted. Here's the same SCOUT image, and I kind of manually drew in where I wanted the beds to be for the CT and PET images. So this yellow one is the body field of view. So we're doing an eye to thigh image. In real life, I probably would have dragged up this yellow square a little bit higher, but the yellow-orange box is the body field of view, and this blue box around her lungs is the lung recon field of view. Here's the first part of the PET report. 6-year-old female, history of metastatic colon cancer. It was an eye to thigh image, and the injection dose was around 9.84 millicuries of F18 FTG, and her blood glucose was 129. And the mean SUV of the liver and visceral background activity is 3.7. And that is the SUV I measured of the liver. The CT scan is limited for diagnostic purposes only, and it's mostly for anatomical location and attenuation correction. So no contrast was used for the CT scan. Oh, and to backtrack, another reason why it's very important to document everything correctly is that everything you input gets part in the patient's permanent medical record, and it is a pain to call IT in order to change things. It could take hours. That's what I'll say on that. This is one of the first slices of the PET-CT. The mass that was the main area of concern that called for the PET-CT scan is highlighted. We're here. So it is a markedly FDG avid mass. As we can see, there's a lot of uptake in that lesion, which isn't necessarily a good thing. This is image 58. Left upper lobe multiple lung nodules associated with diffuse increased FDG activity, with more marked increased FDG activity at the site of confluent nodule opacities with index lesions, SUV being 7.3, image 58. This is image 58. And I believe I have 61 on the next one. I do. And this is image 61. 58, image 61. Here's more of the PET-CT report. I'll let you guys take a look at that. Feel free to pause the video if you want to look at that more. I did want to show some coronal and sagittal images. So looking at the coronal images, you can see this increased uptake right here, as well as the sagittal. And then this bright spot right here, that's her bladder. That's a normal finding because that radiopharmaceutical is excreted through the bladder. And that is why we always ask them to urinate before eye to thigh tumor imaging studies, because everything will scale to this bladder versus our main areas of interest. And you can tell right here that she does have some abnormal colon uptake. And she does have history of colon cancer, if you remember from the first part of this presentation. Here's more images. And then here is her MIP image. So, like most of you guys know, I'm sure, all of the dark black areas are areas of increased uptake. So some of them are normal, some of them are not normal. Like I said before, bladder uptake, as well as the kidney uptake, that's pretty normal because that's how the radiopharmaceutical is excreted. But all of this stuff up here, not very normal. So on the left, this is a posterior and left lateral. Here is an anterior and right lateral MIP image. And I wanted to put a side-by-side of the previous CT as well as the PET data. And this is the measurements that the radiologist used for generating the report. So on the left, this was the main area of interest. And then here is the radiologist measuring the SUV uptake of that pulmonary nodule, where they concluded that the SUV is much higher than the 3.7 SUV of the liver. So, like I mentioned in the peer review article, the higher the uptake, the more chance of it being malignant versus benign. And here's the impression that the radiologist made from the PET CT. Left upper lobe anterior mediastinal pleural based, 4 times 2 centimeters, markedly FDG avid mass with an SUV of 19.2, compatible with malignancy. I'll let you guys look through the rest of the impressions. She's also had some, as you read, also had some lymph nodes that were FDG avid as well. Thank you for listening. The reason why I chose this particular study is that this was the first PET CT that I more or less did entirely by myself, minus setting the IV and injecting the radiopharmaceutical. So this one will always hold a little special place in my heart. And I decided, or I found out that I really do enjoy PET CT. I think it's very fun and it's very interesting, even though the majority of the scans are pretty straightforward and easy to do. I just think that they're really fun to do. So I enjoyed my PET CT rotation a lot, and I think once you guys have your PET CT rotation for those that haven't. You'll enjoy it a lot as well. Um, but thank you for listening. If you have any questions, please feel free to comment. I hope you enjoyed it. Thank you.